All right, so I'm going to get started. Any questions on any material we covered from last time? We did ophthalm, we did kind of the first half of the ENT stuff, got over some antibiotics and whatnot. Yes, ma'am.
This even pertains to what we just learned, but I just have a question about the BJP pneumonia.
Yeah.
You know how that's fungal?
Mm-hmm.
Why do we use Spectrum?
That's a very good question. We just find that for whatever reason that PJP happens to have the ability to be affected. So it's using folic acid, just like, we use folic acid, just like, the bacteria use folic acid. So that one happens to be susceptible through that pathway, right? You may find that a lot of other fungus does not work with Bactrim, but for whatever reason, that one typically has susceptibility to Bactrim. And so we can utilize that both for prophylaxis and treatment, and tends to work pretty well.
So what if you can't use like diflucan or
something? That I would have to look at. The thing is like, you don't see it really that frequently unless you really work with that patient population. So for instance, and again, I'm not an infectious disease specialist, I don't work with those patients all the time. If you did worked in like an HIV clinic or something, you would definitely see it more often. Where I see it most frequently is just from the prophylaxis standpoint. So in those cases, we don't really have to worry about using anything else. We can use Bactrim. Like I said, we'll do like a Monday, Wednesday, Friday sort of thing, and then I've not seen any cases, at least working with those patients over at Nemours, that develop anything. I've seen a few cases like in the adult ICUs or something for some of those really more immunocompromised patients who have been kind of dealing with it for a long period of time. But yeah, I don't know. I actually had to look or delve much deeper into further treatment options because Bactrim has just kind of always worked. Yeah. Good question though. Anywho, right, so getting into the rest of this, we're talking about systemic antihistamines. Okay, we talked about a few antihistamines you can use for the eye. So obviously, what are they doing? They're blocking histamine receptors, right? They're antihistamines, right? So just at the very basic, they're blocking those receptors there. And so two main types of histamine receptors we're going to focus on. Anyone know the types we have? H1 and H2, right? H2, where do you primarily think about those residing? The GI tract, right? In the gut. Yeah, H2, I'm sorry, H2 is going to be in the gut, right? We're primarily focusing on H1 here, right, because we're talking about ENT stuff. H2 is primarily in the gut. We'll cover that in the GI section later on. I think that's in section 3 of this class. We're talking about H1 receptors primarily here, right? So when you're thinking about like systemic inflammatory responses, you're thinking about allergic responses, you're thinking about H1, right? So these are the drugs we're going to be focusing on, at least for our purposes right here. Now, again, when you see an allergic response occurring, you're going to get a lot of redness. You get a lot of those blood vessels will dilate. They tend to become more leaky when you do that, and you're going to see that fluid leak out. That's why you see the edema associated with that. You're going to find it, and remember when we talked about mast cell stabilizers versus antihistamines last time, which one tend to work faster? Antihistamines, right? Because they're dealing with the histamine that's already been released versus the mast cell stabilizers. They only work if we're using kind of before those mast cells have degranulated. So again, this is going to be very good fast-acting medications. They're going to be very good for dealing with acute inflammatory responses that are actually occurring. So again, don't get too hung up on all the different peripheral effects we're going to be looking at here, but just know that the H1 receptors is the primary thing we're going to be focusing on as far as affecting things like permeability of the vasculature. One of the big things we'll talk about when we get to pulm is actually anaphylactic reactions, and one of the big things you'll see with that is actually hypotension. They can develop shock in those cases because of the massive vasodilation they have from all the histamine and some other inflammatory mediators. But you'll also see antihistamines are a big drug we're going to be using for treatment of that as well. So this will be a good kind of lead in to talking about some of the pulm stuff later on, since this is all kind of allergy mediated, right? As I mentioned, H2 primary thing you're going to see is in the gut. We'll talk about those a little bit later on. Anyway, so again, looking at this, you're seeing that increased permeability. That's why you're getting the swelling. That's why you're going to be getting the fluid leak. That's why you're going to be getting all those effects there. Other big things to note, though, as well, are going to be things like increased mucus secretion, right? That's why you end up seeing patients when they have allergic responses. What are the symptoms they develop? Runny nose, runny eye. Yeah, eyes are going to be watering. So you're expecting to see a lot. The lungs can also kind of gunk up with mucus in a lot of cases there as well. So maybe having some productive cough associated with that. Again, that'll be important. We're talking about things like allergy from the pulmonary system later on. But again, these are the things we're dealing with, right? Typically, we're going to see some increase in smooth muscle tone. Actually, nerve endings can become more sensitive when histamine's been released, which makes sense because if you're having like an inflammatory response, your body's trying to tell you that something bad is going on, right? So by kind of sensitizing those nerves, you're kind of getting the signal there a little bit more strong in those cases. And then one of the big things is bronchoconstriction. This can be potentially problematic for your asthmatic patients or anyone having bronchoconstriction. This is the life-threatening sort of thing we worry about, which is why we use antihistamines a lot for those pulmonary manifestations. Anyway, H2, this is responsible for a lot of hydrochloric acid secretion. It's going to be in the stomach. Again, don't get too hung up on this right now. We'll talk about that later on when we get to GI in a couple of sections. Anyway, so some other peripheral effects. Again, we're going to find that when we use H1 antagonists, right, and again, specifically this H1 receptor antagonists, these are going to be good because they're going to help to block a lot of that vasodilation. They're going to help to decrease the secretions we're seeing with that, so a lot of less mucus secretions. We're also going to find that a lot of these H1 antagonists we're using don't just work on the histamine receptors. They're also going to have a lot of other effects as well. Mainly, they're going to be working on the muscarinic receptors and blocking those. Okay, remember, muscarinic receptors are kind of associated with which nervous system? Cholinergic, also known as parasympathetic nervous system, right? So the parasympathetic nervous system is going to be affected here pretty strongly by these drugs because a lot of them have antimuscarinic activity, okay? Now, have I talked about the mnemonic that I use for antimuscarinic activity? All right, I'll cover that in just a few minutes here. That's going to be a good mnemonic to remember for like rotations and stuff when people ask you, hey, what are the effects of this drug going to be? It's antimuscarinic. You'll know right off the bat, right? But anyway, when using an H1 blocker, you're going to find decreased itching, decreased hives, all this good stuff are be able to be blunted. All these allergic responses are blunted with the antihistamine. Now, the other big thing, you're going to find that we have two main classifications for H1 blockers. You're going to have the first generation and second generation, okay? So it doesn't get as complicated as like the cephalosporins as far as that goes. But the big difference between these two is that the first generation will cross into the CNS. It can cross the blood-brain barrier. Second generations do not. Okay, that's the main difference. So it's going to be important from a side effect profile, okay, as we're going to see in a little bit. Big things you're going to see from the first generations as they cross into the CNS is you're going to be seeing that a major side effect is what? Sedation. Has anyone ever taken Benadryl before? Most people probably have. You probably get a little sleepy when you're on it. Now, have you ever seen someone who has an opposite reaction and we get really kind of wigged out on it? That is also what we call a paradoxical response. And I always have like one student who's like, I don't ever get sleepy. I get totally wigged out. That's okay, right? So again, you're always going to find some people are exceptions to that. Some people get maybe a little bit more anxious on something like a Benadryl, but for the by and large, most patients develop sedation. Okay, when you have the opposite effects occur like that, you call that a paradoxical response. In some patients, you just never going to have that. Be careful because again, if you're mixing this with other medications that can cause CNS depression, those are going to be synergistic, right? So again, if you have someone who's having trouble sleeping, they take a Benadryl and they're like, oh, let me go ahead and have a glass of wine, they're going to be much more sleepy than they would be if they had one or the other, okay? So be careful with that. I always recommend to avoid mixing and matching your CNS depressants. This goes for any other drugs, you know, benzodiazepines, seizure medications, anything like that that's going to slow down the CNS. Now, that can be a good thing. Sometimes we'll use these for those sedation sort of effects. So if you ever see Unisom, that's an over-the-counter product that's specifically recommended for sleep. And again, you always want to be careful because a lot of these agents tend to be more habit forming, right? So it means that if I have to take a doxylamine every single night to get to sleep and all of a sudden I don't stop taking it, you typically they have a harder time going back to sleep, right? Than maybe they had in the first place. So you got to be careful with any of these. I wouldn't call this like addictive as you would see with some of the other medications, but we'll talk about those later on. Anyway, as I mentioned, some patients will develop that restlessness and that excitation. This can either happen at lower doses for some patients who are particularly susceptible to this. We see this more with kids. Sometimes you give them a Benadryl and they just kind of wig out. They're crawling off the walls. They're going crazy. We also see this quite frequently at really high doses as well. This is actually a big class of medications that adolescents will abuse in order to get high because it is very available. A lot of these are over the counter. They can go buy Corsican cough and cold, get a bunch of chlorpheniramine, and actually get high off it. Not that I recommend that. Not recommended at all. I had one patient who was at a party. He was an adolescent, had overdosed on way too many of these cough and cold drugs. Came in and, you know, for like a normal seizure, a drug we use is called Ativan or lorazepam. Normal seizure I can treat with 2 milligrams and the patient's out, right? Stops the seizure, patient probably falls asleep. This kid got 14 milligrams before he was just calm. Like he kind of nodded off a little bit, but he's still kind of fasciculating and it was very strange. So not a very good high. Again, don't recommend this to any of your patients for that purpose. Anywho. But the big difference here is that the second generation agents do not cross the blood-brain barrier. You do not see sedation with that. Okay, so if I ask you on a test and I say which one of these antihistamines is most likely to cause sedation, your job is to identify the first generation agent. Okay, or if I have a patient who's taking a CNS depressant, and I'll give you, I'll tell you specific. I'll say, his patient's taking Ativan around the clock. It's a CNS depressant. Which one of these would you want to avoid mixing with that? You would have to identify again the first generation agent. Okay, those are things I can kind of ask. Other things you're going to find is that the first generation agents working in the CNS, they tend to have some other effects as well. So for instance, you can use these as antiemetic drugs in some cases. You can use these as antimuscarinic drugs, meaning they're going to stop secretions. And here's the mnemonic I use. Now, if I talked about the cholinergic mnemonic, okay, so here's two mnemonics that are going to be very good for you, right? So write these down. For cholinergic acting drugs, right, these are muscarinic acting drugs. So if I had something that activated muscarinic receptors, the mnemonic I use is called dumbbells. Okay, these are things activating the parasympathetic nervous system. Does anyone know what happens when you activate the parasympathetic nervous system? Makes you leak, absolutely. So this is the dumbbells kind of speaks to that, right? So the dumbbells is going to be diarrhea. Okay, patient's going to develop diarrhea. Again, they're having secretions everywhere. Anyone think of what the U means? Urination, perfect. M has to do with the eyes. Meiosis, right? So you're going to see meiosis with that. Now, the B's are what we call the killer bees, especially in the tox world. This is going to be things that can be potentially really problematic for your patients. It's going to include bronchorrhea, so again, you're making all the secretions. Because bronchospasm, it's going to cause smooth muscle constriction there. And it can cause bradycardia. Because again, you have those muscarinic receptors on the heart. The vagal tone is going to increase. You're going to see bradycardia associated with that. Okay. Anyone know what the E means? Emesis, absolutely good. L? Lacrimation, good. And the S? Salivation, good. Absolutely. Again, so again, a lot of secretions you're going to be seeing along with this. Okay, so dumbbells is the muscarinic mnemonic we use to remember the effects there. There's only one L. Again, oftentimes our mnemonics are not spelled correctly. That one is D-U-M-B-B-B-E-L-S. So again, we just use some things as they become convenient to try to help us remember. Anyway, so those are the cholinergic, those are the muscarinic effects you would expect to see, right? Those are not nicotinic effects, those are muscarinic effects specifically. Now, the opposite of that, which is what I'm trying to get to as far as the side effects you can see from antimuscarinic drugs, like a lot of your first generation antihistamines, it's a little different. It doesn't actually make a word necessarily, but it's a little saying we have. So one of the things is going to be mad as a hatter. Okay, so in high doses, you're going to find this can cause ultramental status. Low doses, you see sedation. Higher doses, you end up seeing a lot of excitation. Okay, you get mad as a hatter. Does anyone know where mad as a hatter actually comes from? It's actually mercury poisoning. Yeah, so you saw mercury toxicity from felters. There are people who are using hats or making hats back in the day. Anyway, but again, don't get confused on that one. But just know that was originally had to do with mercury toxicity. But mad as a hatter, so you see ultramental status. They get dry as a bone, which makes sense because you're blocking the muscarinic effect. So instead of having a bunch of secretions by activating it, you're going to dry out, right? So you can see things like urinary retention. You're going to see things like constipation. You're going to see things like dry mouth, the dry eye. That's all going to be the dry as a bone aspects of it, okay? They're going to be hot as the hair. Not that hairs are particularly hot. Hot as Hades, some people say. They tend to get hyperthermic, okay? They're going to be blind as a bat. So you typically see mydriasis, and they're going to have impaired accommodation. That's why anyone ever had their eyes dilated. Usually they use antimuscarinics, like we talked about with the eye stuff, and they have a hard time seeing because they can't really accommodate very well. Okay, and then the last one's going to be red as a beet. They have a lot of vasodilation, so you end up seeing that they get very flushed in those cases. First one's mad as a hatter. Yep. So mad as a hatter, dry as a bone, red as a beet, hot as Hades. And what was it? Blind as a bat, thank you, yes. Again, doesn't go to the specific order, so mad as a hatter, dry as a bone, red as a beet, blind as a bat, hot as Hades. Okay? And you can go back to the lecture or the video and go back to that. I'm sorry? Yes, so the mad as a hatter is the ultramental status. And again, the other thing is you're going to see a lot of tachycardia associated. So some people will say go through all those 5 and then saying the heart runs alone. So there's going to be tachycardia because, again, you're taking off that muscarinic effects on the heart there, okay? So, again, those effects you'd expect to see when you have something with an antimuscarinic activity. Yes, sir? Red as a beet. Yep. So anyway, so again, because of these actions, these are good because, again, we mentioned when you're having an allergic response, you're having a lot of secretions. So the antimuscarinic effects are really good for drawing someone out, right? And that's good because if I have someone who is, for instance, like I have really bad, if I'm going around animals that I'm not really used to, I end up having a lot of like allergic response to that. I will take a Benadryl or diphenhydramine because that will help to dry me out as well. Not make me a little sleepy, but it will help to dry me out and deal with a lot of those symptoms there, which can be really good. That's the antimuscarinic effects. Okay, and then a lot of these are also going to be used as antiemetic drugs. Some of these can really help with vestibular disturbances. So a lot of these are used for motion sickness as well. Okay. So again, the antiemetic actions are often mediated through the antimuscarinic activity. They can work kind of directly on the chemoreceptor trigger zone, which is going to be mediating a lot of nausea, vomiting. We'll talk more about that later in the GI section. And actually, one of the big ones we use quite frequently, and this is prescription only, is one called promethazine or Phenergan. Phenergan is a very, very strong antimuscarinic activity, works very well for things like motion sickness. So a lot of people will come into the ER, they're very motion sick, they're having nausea, vomiting. Oftentimes we'll give them like a suppository or an IV form, because again, if they can't take anything by mouth, we have to find an alternative route. It works very, very well. Just a aside, one time when I was, this was before I was even in pharmacy school, just to give myself some legal out here. I was very, very sick. I developed I was just throwing up like crazy, just some viral illness, most likely. And my aunt was like, "Oh, I have these Phenergan here. You should try this Phenergan, and that should help you." I said, "Great, let me try that out." And so I tried one. Again, it's prescription only, so technically that was illegal, which I probably shouldn't be saying on recording here, but I taken it and I fell asleep for like 10 hours straight. I woke up, I was completely dry, like all over, but I felt great. And so I was like, wow, that's a heck of a drug right there. So very, very good, very strong drug, but a lot of those side effects associated with that, right? So again, a lot of dryness, xerostomia, dry mouth, dry eye, things like that you're going to see.
Is this safe during pregnancy? Is this the one we can do?
That is one you may use in pregnancy. There's also some other ones we'll use potentially ahead of that, because again, there are a lot of side effects associated with it. So again, if I needed to go operate heavy machinery, not a great drug, right? Because I'm going to be way too tired to do that. I don't want to be operating a crane and kill someone or something, right? So again, I wouldn't want to be driving, things like that. So we try to find drugs that are non-sedating, which can be beneficial in most cases. So anyway, indications, like I said, motion sickness, we'll use these for over-the-counter sleep remedies, allergic reactions, and again, this has a big role to play in anaphylaxis as well, as we'll see. Big adverse effects, as we mentioned, sedation, GI disturbances, mainly things like constipation with a lot of the antimuscarinic activity. You're going to find, you may have some increasing GERD symptoms, but that's the main thing. And as I mentioned, urinary retention, blurred vision, dry mouth, all of that is the antimuscarinic effects. And this is more primarily seen with the first generation drugs. You miss a lot of these side effects by using the second generation agents, which do not cross into the CNS. Okay. So here are the drugs to focus on here. So we have drugs like chlorpheniramine, dimenhydrinate, which is Dramamine, diphenhydramine, hydroxyzine. This is a good prescription product we use quite frequently in the hospital. We have things like meclizine and then promethazine. Okay. Again, don't really note necessarily the duration of action so much, but what I do want to just kind of highlight here is if you notice the sedative effects, the antiemetic effects, and then the anticholinergic effects, notice these are all medium to high versus when we move down to our second generation agents, very low to none. Okay. Again, all this is mediated through the brain, but if you can't get to the brain, it's not going to have those effects. Okay. So then we have the second generations, and again, for a while these were all prescription, but now all of these are going to be available over the counter, with things like cetirizine, fexofenadine, and then loratadine. Okay. Now, they have started to make some enantiomer forms of these. So, for instance, there's like a levocetirizine that's out there. Well, now it's another prescription product. They got another patent on it. They can make some more money off of it. Just use over-the-counter stuff. It's going to work just as fine as any of that other stuff, okay? So don't get, just because the reps come and buy you a nice lunch and take you out, don't fall for it, right? Go with the over-the-counter stuff, so what your patients can afford. There's an intranasal antihistamine. This one does not get used as frequently, but azelastine, we already saw this used for the eyes previously, so it has the same effects, just a different formulation used for the nose, right? Okay.
In the 3 second generations, is there one that has like the least sedative effects?
I find clinically, and this is actually kind of interesting, so when you're looking at the effects of the 3 of them, I would say that fexofenadine and loratadine are both pretty equal as far as not really having many sedative effects. They also tend to be the weakest out of the bunch as far as treating those kind of acute sort of allergic symptoms there. Cetirizine, though, actually, one of the metabolites of it actually happens to be hydroxyzine. Hydroxyzine we saw as a first generation can actually cross over. So because of that, cetirizine tends to be a little bit more potent at treating those allergic symptoms, tends to be a little bit more sedating than the other two. So if I had to choose one, I want a little more punch, I like to use cetirizine, right? If I had someone who's just taking it for kind of like daily allergies or seasonal allergies and really didn't, more as a prophylactic, any of the other two would work totally fine as well. But if I'm treating something, oftentimes I'll use like some Zyrtec, right? Anyway, azelastine, as I mentioned, it's a nasal spray, used, again, not as convenient as just, taking a pill for a lot of patients, but again, if they're just having strictly nasal symptoms, this can be a good option for them, as the case may be. And again, usually better taste is one of the main side effects you see with that. In some cases, you have to worry about nosebleeds, but pretty minor from this standpoint. And why do you think they might develop epistaxis? The antihistamine. Yeah, the drying out of it, right? So again, you think back to the mechanism, and it'll explain a lot of the side effects you end up seeing with the drugs. All right, so moving in, next we have the ENT corticosteroids. So what role do you think corticosteroids have to play here in decrease inflammation? Absolutely. So these are really good for more kind of chronic allergy symptoms, seasonal allergies, things like that. These are going to be good for long-term use. Because remember, antihistamines, we said the onset of action is what? Pretty quick, right? Steroids, it's going to be slower. They're going to take a while to work because, again, they have to go down to the nucleus and change transcription, right? They're going to take some time to work. They also have to be used consistently, okay? You just can't take this one-time dose and say, okay, well, I'm good to go. You need to take it consistently to make sure they're going to maintain that effect, okay? Antihistamines are good for kind of a quick fix. Nasal corticosteroids. So for instance, when I went to Ohio recently to go see my brother, he has a dog. I said, okay, well, I don't have enough time to take a nasal corticosteroid beforehand, so what I'm going to do is when I get there, I'll take an antihistamine, right? So I took some Zyrtec, and I was fine, right? Versus something like this, I would want to take weeks beforehand before I really start to see kind of the full effects there, right? So the onset of action will be a lot slower for these, but these tend to be very powerful, right? Because they're able to help, really mitigate all that inflammatory cascade as opposed to just working on one aspect of it, which is histamine. Histamine's important, but there's other ones that are out there, right? So the leukotrienes, thromboxanes, etc. Only working on one aspect of it, okay? Does that make sense? Anyway, a couple of these, and note, we're going to talk about these again in PULM, so these are going to come back up. We have things like beclomethasone, budesonide, fluticasone. Most of these have a counterpart that's going to be inhaled for use in management of asthma. Some COPD, but mostly asthma, right? So for instance, this is a big one we mix up all the time, is fluticasone, Flonase versus Flovent. Right? Sometimes the brand names will kind of key you in as far as what the actual use is going to be. So, for instance, you have something like, budesonide is Rhinocort. The brand name will be Pulmicort. Right? Pulm, you think lungs, right? So, Rhino, you think nose. So in those cases there, you find that the brand names can help you out a little bit, but really be careful. Make sure you're looking at the dosage form. If it says nasal spray, it's probably going to be for seasonal allergies. If it says an inhaled, inhaler, it's going to be for asthma symptoms, right? Keep those in mind because it's a common medication error that will screw up, and so this is one case where the brand name can kind of help you out a little bit. So anyway, these are frequently used for allergic rhinitis, vasomotor rhinitis. Again, only going to be good for the nasal symptoms. These are working locally, which is good because they're going to help them, really limit systemic side effects you're going to be seeing from these, right? We know the corticosteroids have a lot of systemic side effects. So by using these nasally, you avoid that and just kind of work locally. And again, side effects are going to mainly be related to things like epistaxis. You can see septum perforation very rarely, which makes sense because corticosteroids usually do what to wound healing. Just slow it down, right? So any damage you do may not heal very well if you're applying these steroids every single day, right? And again, some unpleasant taste there. Again, little to no interactions because, again, you're not going to be using these systemically. They're just working locally, so no real drug interactions to worry about, which is nice. Okay. Now, on the other hand, we have some drugs that we can use systemically. Say a patient comes in, they're just having really severe allergic symptoms. Sometimes you can give them a short pulse dose sort of therapy with systemic corticosteroids, right? So again, if they're something where they're just coming in and the antihistamines just aren't working for them, or they're maybe not a good candidate for that, using systemic steroids can help out, right? So as opposed to the nasal steroids maybe taking like a week or two before you really see full effect, things like these systemic steroids maybe a couple hours before they're really going to start to kick in. So much more potent, much more fast acting, however, a lot more side effects associated with them. So here's just a couple we'll use very frequently for management of some of these symptoms. One's a big one is dexamethasone or Decadron. Again, working just like cortisol does in the body to decrease inflammation, but the side effects are the big thing you have to worry about, right? Things like worsening CHF and hypertension and causing more fluid retention. Why do you think that happens? Yeah, so it's going to have some mineralocorticoid effects, right? Again, every steroid is going to have a little bit of corticosteroid, some mineralocorticoid. Some are going to be more one versus the other, but again, they all tend to have a little bit of bleed over there. So in this case, due to the mineralocorticoid effects, which acts just like aldosterone does, you tend to hold on to salt and you hold on to water, right? In the kidneys, wherever salt goes, water follows, right? So again, this is why you end up seeing worsened CHF and things like edema, things like that can happen. They tend to be glucose intolerant, so it's a glucocorticoid, so it's going to increase glucose production in the body, and then you end up seeing kind of this litany of other symptoms that occur here, things like hirsutism, Cushing's sort of effects there, potassium loss, that goes back to the aldosterone as well, all these things. Now note, we're using these for short courses typically for these indications here. This is not going to be like an everyday thing continuously like you would use for something like rheumatoid arthritis, which we'll talk about later. So some of these are going to be just around while they're on the drug, and then probably won't be that big of a deal clinically. However, if I had a really sensitive sort of CHF patient who was just teetering on the edge of having an exacerbation, this could be the thing that pushes them over to the edge. Okay, so otherwise healthy patients, though, for 5 days of therapy, not going to be a big deal. Diabetic patients may need to dial up their insulin if they're on insulin. They may need to just watch their sugars a little bit more closely while they're on these for that short course. Okay, so just kind of keep in mind the duration plays a role as far as the side effect profile. Again, if it's less than 5 days, you do not need to taper them off of their dose. Okay, if it's more than a week, more than 5 days, I would say yes, you probably want to build in a taper. Now, most of the time you may be prescribing something like methylprednisolone, which comes as a solumedrol dose pack. That has a taper already built into it, right? So in that case, you don't have to do it, but it's already built in anyway, so it doesn't really matter. But for these cases here, if you did 5 days worth of dexamethasone, I don't have to worry about tapering, which is good. Okay. Again, other side effects you can see with this are drug interactions, worried about, diuretic sort of effects here. We'll talk about diuretics more in the cardio section coming up in a little bit. Things like macrolides can affect the clearance. You decrease the clearance, you see more corticosteroid side effects, right? You obviously decreasing the effects of anti-diabetic meds. Well, if I'm checking up the blood sugar, that makes sense that your diabetic meds are going to work less effectively. So a lot of these make sense based off of either the pharmacodynamics of the drugs interactions or the kinetics of it.
Can you explain that mineral thing you're talking about earlier?
So every steroid basically either has glucocorticoid effects, which are mainly focusing on glucose homeostasis, right? And then you have the mineralic corticoid effects. So mineral, I think mineral, salts, I think fluid, right? So the mineralic corticoid effects are mainly, the aldosterone is the main endogenous sort of mineralic corticoid that we have. Okay. Normally aldosterone, when it gets expressed, you're going to be holding on to sodium. You're going to be losing potassium. But again, sodium is in a lot higher percentage in the bloodstream than potassium is. So by holding on to that sodium, you're going to be holding on to more water as well. Okay, so that's why you end up seeing that patients with CHF, they tend to have, they may put on some weight after they start it because they're going to be holding on to more water. And again, water weight's a big thing to worry about with CHF. So that's a big thing you see, right? Mm-hmm. Okay, things to worry about, if there's a contraindication, probably fungal infection would be the big one just because that will limit your ability, your own immune system to fight that off. Again, these are immunosuppressive sort of drugs here, but just, again, don't have to discontinue. I'm sorry, you don't have to do a taper if it's less than a week. If it's greater than that, though, you do want to taper them off, okay? And why do we do that?
You want your kidneys to produce enough.
Well, not kidneys, but the adrenal gland, right? Yeah, you want the adrenal glands to make sure they're not going to atrophy and have an adrenal insufficiency, right? So again, if it's greater than that, because again, once you supply exogenous corticosteroids to the body, the adrenal glands say, hey, I have enough around here, I don't have to do anything. That negative feedback loop gets activated and it stops production and they atrophy, okay? So just something to keep in mind. Prednisone is another big one we use pretty frequently. Prednisone is the tablet form. Prednisolone is the liquid form. So we use a lot of prednisolone over at the PDR, but like an adult ER, you may see more prednisone being used. Okay, that's the only thing. Prednisone actually gets converted over to prednisolone, so functionally they act like the same exact drug. It's just when you see prednisolone, just know you're dealing with the liquid form. Again, same side effects. Same thing you would expect to see, with dexamethasone. No differences there. The only thing you may see different is the dosing might be a little different. Dexamethasone tends to have a lot longer duration of action. Prednisone is a little bit shorter. So, for instance, this is just an example of what we do for asthma exacerbations when a kid comes to the ER. If we send them home on steroids, if we do prednisone, it might be on prednisone, say, 1 dose daily for 5 days, or maybe 1 dose twice a day for 5 days. On the other hand, dexamethasone, because it's a longer half-life, we can actually give them a dose in the ER, and we'll give them 1 more dose that they'll take 36 hours later. And functionally, by taking those 2 doses, it covers that same 5-day period as prednisone would. So dexamethasone has a longer half-life, prednisone has a shorter half-life. That's really functionally the big difference between these two.
So prednisone is a corticosteroid and dexamethasone is like both mineral and
So prednisone will be both as well, yeah. So they both have that, they'll bleed over, yeah. So you end up seeing functionally the same side effects between the two there. We talk about them as a glucocorticoid because that's the effect we're looking for, right? We're not using them for their mineralic corticoid effects. We're using them for the anti-inflammatory effects. We're using them for that. So that's why we kind of talk about them more as a glucocorticoid rather than as both, essentially. Absolutely, yes. Anyway, again, so I'm not going to belabor these points. Just know the side effects are going to be functionally identical between the two. Again, always be careful with immunocompromised individuals because, again, you're going to limit their ability to fight off infection. Also avoid things like, like live vaccines. We'll talk about vaccines later on, but just know that whenever you're doing that, you're impairing your ability to actually fight and produce new immunity against those live vaccines. Okay. Anyway. Then next up we have the ENT decongestants, and so what do these do for us? Yes. Decongest, right? They're gonna. How would they decongest? What do you think they're doing? Vasoconstriction is gonna be the big thing we're gonna be seeing here, right? So ENT decongestants are vasoconstrictive agents. Okay. First one we see here is gonna be oxymetazoline. Now this is very similar to some of the drugs we talked about in ophtho. So if you remember, we talked about vasoconstrictors there, namely like tetrahydrozoline, nefazoline. Those were going to be drugs that were acting as vasoconstrictors. This is no different here, right? What was the big thing we talked about, the big side effect you worried about with prolonged use of something like tetrahydrozoline? Rebound, hyperemia. Same thing goes here, okay? You're going to see this rhinitis medicamentosa is what they call it when you have this rebound nasal stuffiness that occurs here. But Afrin, the nasal spray, is going to be working on the alpha receptors within the nasal mucosa to constrict that and limit that leakiness, right? You're going to limit that edema that forms there, and that's going to help with the congestion. We do not use this more than 3 to 5 days. Use it beyond that. Patients, again, they're not addicted to it. It's not really an addiction, but they develop a physical dependence on it, okay? So that way they stop taking it, guess what? All those vessels are going to start to blow wide open again, and they're going to have that rebound stuffiness that's probably worse than what they started with. So be very careful with this. Actually, I knew one pharmacist who was very dependent on Afrin, and he had 3 bottles of it across the counter. He had a big long counter. He had one on each, 2 on the end and 1 in the middle, and he would just kind of shoot up every couple minutes or so because he was so dependent on the stuff. And if he stopped taking it, he's going to have the really nasty rebound congestion there, right? So it's very. Medical providers are often the worst patients. We know better about a lot of things, but we still do a lot of dumb things to ourselves, right? So, you ever met an alcoholic provider? You ever met a provider that smokes? You know, I mean, like, you're going to find people out there that they know better, but they'll, yeah. Unfortunately, we're still human, as the case may be. So, anywho. But again, this is one of those things where actually another indication you might use this for. So it's a vasoconstrictor. Where else might that be useful within the nose? Bleeding, yeah. So sometimes you can actually use this for epistaxis. You can use this to try to constrict those vessels and limit that bleeding there. So that's one thing you may see. Again, watch out for that rebound rhinitis. Now, again, we like to use things locally because they limit the systemic side effects. You still can see some absorption there. So, for instance, if you have a patient with uncontrolled hypertension, this may worsen that. Or if they're controlled on medication, you may find this can still raise their pressure up. So, again, not the best drug for a patient with hypertension. However, this is going to be better than using something that's more systemic, as we'll talk about. Do you know any systemic decongestants you can use? Over the counter, actually not over the counter, it's behind the counter. Sudafed is going to be a big one there, right? So we have pseudoephedrine or Sudafed. Why is that behind the counter? You can use it to make methamphetamines, right? So if you watch your Breaking Bads or whatever show of choice, I like Breaking Bad, but that's it's something where you can actually use Sudafed to produce methamphetamine. So because of that, they thought it was a very big concern. They had to move it behind the counter, right? So that's why you have to show your ID. You're limited to how much you can actually get every month because of those issues, right? Now, instead, what do they do? I mean, because you can go out, to the Walgreens, you can find Sudafed on the shelves, but what's the caveat there? What's different about it? So they may have dextromethorphan. It depends on the product, but do you ever see like Sudafed PE? You ever see that before? Next time you go to like a CVS, Walgreens, Walmart, or somewhere, go peruse the cough and cold section. You'll see Sudafed there on the shelf, but it says like Sudafed PE. You know what PE stands for? Not pulmonary embolism. It's for phenylephrine. Okay, so it's a different drug, one you cannot use to make methamphetamines. And so they say, well, here's Sudafed PE. We're just going to put this on the shelf. So that way, people will still think about Sudafed. They still see the drug there. Like, oh, this must be just as good as any other Sudafed, not realizing it's a totally different drug that's in there as a decongestion. Phenylephrine, taken orally, is a very crummy decongestion. It is not a very good drug, and I would not recommend it to any of our patients, okay? They need to go behind the counter, not themselves go behind the counter. They need to get someone who works there to go behind the counter and get the actual Sudafed, the actual pseudoephedrine, because that stuff is going to work much, much better. Phenylephrine is a good drug when used IV, not a great drug used orally, okay? So again, it's one of those things where I will frequently recommend. They're like, man, I took the Sudafed, it just didn't work for me. What kind did you get? Did you get it off the shelf, or did you get it from someone from behind the counter? And that's going to clue you in to say, okay, well, obviously you took the phenylephrine, didn't work very well for you. That makes sense. Go try the other stuff, right? Go try the actual real pseudoephedrine. That being said, though, there are a lot of side effects associated with pseudoephedrine that you have to be careful with, right? You don't want to use this in every single patient. This is not a drug you want to use chronically because of the fact that it's going to be very vasoconstrictive. So that means the main side effect is going to be hypertension, right? So again, this is very good as a decongestion, very good for those nasal symptoms, but you worry about it with patients with hypertension. It's going to cause tachycardia. For some patients, this could be the thing that precipitates, stroke potentially, right? These are things you have to worry about for your patients. So I would definitely recommend getting a blood pressure beforehand. If they're way uncontrolled, if they're sitting at 160s over 100 normally, like this is not a good drug for them, right? But if they're well controlled and they're only taken for a couple of days, this may be something that is an okay option. Okay, so just be aware of that. And obviously, it's going to be interacting with the other antihypertensives, making them work a lot less effectively, obviously. Okay, and then one last drug we'll talk about here is the ENT Mucolytic. What does mucolytic mean? Yeah, it's going to be lysing up the mucus, basically breaking up the mucus there, right? So again, this is good for chest congestion. When we talk about Sudafed, that's going to be really good for like nasal congestion, right? It doesn't really do anything for the mucus that's like being developed in the lungs as a response to like a viral illness or anything like that, okay? So as a mucolytic, this is going to be good for helping to break up that mucus and allowing the patient to kind of cough it up and get rid of it, right? So this is good for chest congestion, as we'll see. Now, we'll talk about, yes, sir.
If a patient has chronic, let's say sputum, we don't want to get them chronically because we want them to produce sputum, and do we still give it?
Yeah, because it doesn't do anything with the production of sputum, as we'll see. It just really kind of helps to break it up and allows them to get rid of it more easily, right, as we'll see. And one of the big things you'll see as well is that very frequently these are going to be mixed with antitussive agents. Antitussive just means anti-cough, right? And so we'll talk about those in just a few minutes here, probably after the break. Very frequently, you're mixing these two together. So you'll see like Robitussin or like Mucinex with both dextromethorphan and guaifenesin together. That doesn't really make a lot of sense, right? Because I'm breaking up that mucus, but I want them to cough it up, and I'm giving them something to block that cough. So oftentimes I don't recommend that to patients. I say, well, just do one or the other. Like figure out what kind of is more problematic to them and figure that out. A lot of times what their cough is related to tends to be postnasal drip. They need something that's going to be more drying. In those cases, something like an antihistamine might be better for those patients, right? So that's something to think about. Just for instance, like my kid just recently had a viral illness, and you could tell she's having that postnasal drip because she'd go to sleep, and all of a sudden she'd start coughing, and then she'd throw up, right? And she wasn't having nausea and vomiting due to the viral illness. It was due to the fact that she had that postnasal drip and getting her gag reflex, and then she threw up, right? Cleaning up milk out of your bed sheets at 3 a.m. is not fun, I will tell you that. But anyway, we gave her some Benadryl, and then it all went away. She's totally fine, So anyway, so we have guaifenesin. Mucinex is the usual over-the-counter brand name you're going to see with that. Again, it's a mucolytic. It's an expectorant, so you're going to expectorate all that mucus up, hopefully. After that, it's going to loosen the mucus and decrease that viscosity. The biggest counseling point you can have to this is just make sure they drink plenty of water. Because, again, if they're dehydrated, either due to poor PO intake, or they're having a lot of diarrhea, or whatever happens to be, that mucus gets more tenacious. It gets more viscous because it is dehydrated. You'll make sure they're drinking plenty of water to help loosen that up and help get it more moist, and they can clear that easier. Okay. Again, really no side effects to speak of, maybe a little bit nausea, vomiting, but it's a very, very well-tolerated drug. Probably not the most effective one out there in the entire world, but it's something that's over the counter. So your patients are going to be using it to self-treat quite frequently. So you want to make sure you're asking these questions like, hey, what are you using that you can get without a prescription? You got to figure out these things because otherwise the patient comes in hypertensive. You may think, oh, they have hypertension. Well, no, they just take Sudafed all the time, right? These are things you have to try to suss out when you're doing your histories, okay? Anyway, again, drink plenty of water. Again, with the caveat with the majority is over-the-counter products, and you'll see these on the labels, is they will put a limit to how long you should be using these drugs for. Why do they do that? Because they're self-treating. They're just saying, oh, I have a cold, I'm going to go ahead and take this drug. What if it's something else, right? What if it's something that's more serious that I need to actually be evaluated by a healthcare provider? That's why they put a lot of those limits on there to say, don't use this more than 2 weeks. Don't use this more than 7 days. Because if it is something more serious, they need to come in and get checked out, right? So again, we see this a lot with the GI stuff as well, because again, if I'm treating GERD symptoms, I'm like, man, I just got the worst, stomach pains ever. I'm just taking these GERD, these Zantac all day long, and they actually have like a GI bleed or something, right? Or they actually have a peptic ulcer. Those are things that need to be evaluated. You can't self-treat those at home. Okay, so just an example. Anyway, so any questions on that? Let's do a 10-minute break. We'll come back and we'll start hitting the pulmonary stuff.